I have the pleasure this morning to moderate the first panel discussion of the conference titled Economic Development and Health Outcomes. Of course, economic development is directly connected to human health in poverty-stricken nations, but also in poor communities within rich nations. Businesses can't flourish, people can't hold jobs if they or members of their family are seriously ill. And moreover, these days, people are exposed to environmental hazards that add additional burdens beyond the historical threats that they have become used to their health and their livelihood. And global climate change is going to make those problems even worse. There are many uncertainties about precisely how climate change is going to affect health, but there's little good news there in the scientific community studying those particular issues. Without the stable governments in the economies, countries have neither the money nor the infrastructure to reverse this terrible spiral of poverty and disease. And such countries and communities need help from the outside, and fortunately, many people and nations want to provide that help, but it's complicated. For this reason, as you know, developing a global partnership for economic development is one of the 8 United Nations Millennium Development Goals, which is a blueprint agreed to by nations to halt extreme poverty by 2015. And one of the world's foremost champions, you know, for improving world health and ending global poverty is Colombia's Jeff Sachs. And a couple of years ago, in a speech highlighting the importance of the UN's Millennium Goals, Sachs made the statement, and I quote him, "The coming decade brings opportunities to cut world poverty by half. Billions of people could enjoy the fruits of the global economy, and tens of millions of lives can be saved. The practical solutions exist. All that's needed is action." And Sachs believes this can be done within a decade or two. And I think there are many in the room who agree with him, or at least would like to do whatever we can to make him right. And for undergraduate and graduate students to be actively involved, I mean, how much better could education be than that? What about the politics? Well, in this country at least, everything important has to do with politics. But I think this is not really a deeply partisan issue. Recent presidents of both parties have recognized the importance of trying to address world poverty and health. I worked for President Clinton, who had HIV/AIDS as a top priority in his administration. I attended meetings in the cabinet room with the president and leaders of major pharmaceutical companies in the early stages to try to talk about how to get affordable drugs to these poor nations. President Bush has also made HIV/AIDS a top priority in his administration and asked Congress to approve the large increases in funding for that purpose. Not always so easy to get the money out of Congress, but the commitment is there. For this morning's discussion, we are honored to have 3 distinguished speakers to discuss their views on economic development and health outcomes. I'll briefly introduce each speaker. I'll introduce all of them right now and then ask them to speak in turn from where they are or from up here, whatever they would prefer. Our first speaker is Dr. Ruth Levine, Director of Programs and Senior Fellow at the Center for Global Development. As you know, the Center for Global Development is an independent not-for-profit think tank in Washington that works to reduce global poverty and inequity by encouraging policy change in the United States and other rich countries. Dr. Levine's work in health economics is in health economics, where she specializes in health and family planning, financial issues in Latin America, East Africa, Middle East, and South Asia. She's had a distinguished career prior to that with the World Bank, Inter-American Development Bank, has conducted research in these areas as her doctoral degree from Johns Hopkins and bachelor's from Cornell. Dr. Arlak Bhargava is a professor of economics at the University of Houston, an adjunct professor in the School of Public Health at the University of Texas Health Science Center. His research is focused on nutrition, population health, child development, demography, and epidemiology in developing and developed countries. Prior to his current position, Dr. Bhargava held teaching positions at the University of Pennsylvania and Harvard. Dr. Bhargava received his PhD in econometrics at the London School of Economics. And Joe Barnes, on the end, is a Bonner Means Baker Fellow at the Baker Institute, where he's worked since 1995. He is perhaps our senior fellow. His chief area of interest is international economics, with a focus on the geopolitics of energy, and he's frequently collaborated with our Energy Studies program here at the Institute. In addition to his research, Joe's staff advisor to the Baker Institute Student Forum, very active student group interested in issues such we're talking about today. Prior to coming to Rice, Joe was a career diplomat with the United States State Department from 1979 to 1993, and he was educated at Princeton University. So I'll start with Dr. Levine. Please welcome all our panelists.
Thank you very much. I'm going to keep my cell phone out, not because I'm expecting a call, but because I'm trying to keep an eye on time. This is really a wonderful opportunity to help with the start of a great marriage of different disciplines here at Rice, and I really want to endorse this idea of bringing disciplines together, each with their own special value and technical expertise and perspective to bring. I think that it's better than the alternative of trying to turn all doctors into public health people, all public health people into doctors, everybody in the world into economists, and economists into people who do something useful for a living. So I really endorse. So I really endorse this effort, and in our very small way at the Center for Global Development, and we are small, we're only about 30 people in the organization, we also try to bring a variety of perspectives to bear on some key questions. And what I'll be talking about today is really how donors can do more good and less harm in the area of global health. Just a small little infomercial to start with. We did do the work originally on million saved proven successes in global health, and really looked at some large-scale successes from smallpox to iodine fortification, to the implementation of DOTS to control tuberculosis, and many others. And new edition came out 2 weeks ago, and this is a free copy that goes to the first person who asks a question. So after doing that work, and that was about 4 years ago now, we really started to think about, well, why not more successes? And particularly, what can donors do to promote more large-scale success in global health, which is why you're all in this room and in this enterprise. So let's just take one step back and look at the evolution briefly of donor engagement in the health sector. So in the 50 poorest countries of the world, more or less about $12 to $15 per capita are spent on health annually. So that's a very small amount of money. Really can't buy much health for that, regardless of the cost of some of the key inputs. Traditionally, about a third to a half in the poorest countries has come from external sources, from donors, primarily public sector donors, USAID, the World Bank, and others. Adding up, maybe 10 years ago, averaged about $1.5 billion a year of official development assistance, but that's only about 5% of total official development assistance. So it's, even though it's very visible, at least in the past, it wasn't really the dominant piece of development aid. And then another maybe $7 billion, if you're generous, for research and development on products that are primarily useful in developing countries. Traditionally, of the donor assistance that went for services and to developing country governments, about 25 or 30% of that money went for purchase of products, and that's changed recently, but I'll get to that in a moment. And we historically tolerated a 10 to 20-year lag time between the time that interventions and products were available to us and our children and the time that they were available to children and adults in developing countries. We lived with that, we accepted it. The central question at that time was really something like, how do we get more health from very, very limited budgets, both developing country budgets and external assistance? And as Carol Medlin discussed, in more or less the late 90s, early part of this century, there were some big changes, all sort of converging at one moment. Tremendously effective advocacy around HIV/AIDS that changed the nature of the conversation about our willingness to tolerate that lag time between when we had the products and when they get the products. That changed the conversation at least as much as the entry of the Bill and Melinda Gates Foundation into primarily funding the purchase of products, first with vaccines and then more broadly, now providing more than $1 billion a year for global health activities. The ramp up in the amount of money available for global health has really been quite remarkable. So just a few numbers. Gavi, more than $1 billion over the past 5 years for childhood immunizations. Now they will be controlling something called the International Finance Facility for Immunization, bringing another $3 to $4 billion over the next 10 years. And an advanced market commitment, which will bring something like $1.5 billion for pneumococcal conjugate vaccine. The Global Fund, almost $3 billion over 5 years, largely for products. PEPFAR, $8.4 billion over the next, between 2004 and 2006. These are not strictly comparable, one number to the next, but I'm trying to just give you an impression of how much money is coming into the field. President's Malaria Initiative ramping up to $500 million a year over the next couple of years. And UNITAID, which is the French championed airline tax, which is being where there are many countries now participating, is expected to generate $300 to $400 million a year for the purchase of drugs. So the pie is bigger or higher. It's cut differently now, whereas in the past, a quarter of the donor monies in global health, or what was called international health, went to the purchase of drugs, vaccines, and diagnostics. Now close to 70% goes to that purpose. And so the pie is cut differently, more for drugs, less for other things proportionately. And it's also cut differently in terms of being cut very specifically for earmarked categorical programs, diseases or interventions: AIDS, malaria, TB, childhood immunization. And even within, say, malaria, micro cut to bed nets, to the provision of artemisinin in combination therapies, and not just any artemisinin in combination therapies, very specific ones. So in contrast to the past, where we had less money but somewhat broader programs, we had child survival programs, now we have more money, much more tightly cut. And the nature of the question has changed over the past 5 years or so, or before that, a little before that, from being how to get more money from limited budgets to how to get more health from limited budgets to how to get more money for health to meet the needs. And a real intolerance again for that time lag. Well, we're seeing the results of that, those achievements and the presentation of those challenges coming out. And again, Carol mentioned some of them. I'll probably put them in slightly different terms. One is that we actually are seeing the emergence of new products that were really, for which there really has not in the past been enough of a market incentive. So through public-private partnerships, largely we are seeing literally dozens if you look at the pipeline between now and say 2011, 2013, the anticipated number of drugs, diagnostics, and vaccines that are coming to be registered, be licensed and registered in different countries is really staggering in TB, malaria, and in the vaccine arena in particular. On the ground, the reality is that the aspirational targets, the big ambitions, really are not being met. There are major achievements in the scale-up of different programs, particularly the expansion of antiretroviral coverage, which has gotten the dominant amount of money and political pressure brought to bear, but we're really not reaching the targets that were set out. And emerging emerging evidence about questions of adherence to to the drug protocols, the strain on health systems, the emergence of resistance, the drop-off and treatment failure. So I think things that could have been anticipated early on when you push drugs through weak systems are coming to be felt. Now, that doesn't mean you shouldn't continue to advance the cause of treatment, but I think we're seeing, as pressure is put on weak systems, what can happen. We're also seeing that some of the decision makers in developing countries, in the ministries of health, as well as in regulatory bodies, may not be as ready, as Carol was suggesting, may not be quite as ready to instantly accept global recommendations or the products when they become available, even when they're currently funded with donor money, as we might have expected. And that's because many of these countries have been burned before. With Ethiopia, which spends $8 per capita on health care, now facing two-thirds of a huge expansion of donor money, two-thirds of that being directed only at the purchase of antiretrovirals. They're saying, okay, you put people on antiretrovirals, they're your patients. They're not our patients. So that represents a huge challenge for donors. So we're seeing now, I think, an emerging recognition that it's not just about asking for more money, and it's not just about making new drugs. We have to think about ways in which the money can be used in ways that provides really constructive incentives for providers, for patients, for communities, for policymakers, for developers and manufacturers of new technologies to promote health. Designing those incentives is a tremendous challenge for donors, and one of the reasons it's a challenge for donors, which may not be immediately evident unless you work in this kind of crazy world, is that donors are responding to a whole set of constituencies and incentives themselves, to their own political, to their parliaments, to the advocacy groups in Europe and the US, that may have a completely different set of objectives than either the policymakers or the communities or the providers or the patients on the ground. And so the investments that donors may be willing to make because they're responding to their own constituencies may be attempting to introduce technologies that are not the highest priorities for those who are actually the intended beneficiaries of the products. So I think one of the issues around developing incentives is to more closely align the priorities of those who are affected by global health problems in developing countries with the donors themselves. Let me just take a couple of moments to focus on one angle on those incentives. In the area of how donors affect the incentives faced by developers and manufacturers of new technologies, which I understand to be a key issue, key interest here. It's important to understand, as you in your business understand probably better than I do, how the development of new technologies requires a long-term perspective, an understanding that many attempts will fail. It's not a sure bet. High failure rates from the point of scientific discovery all the way through the end of the product pipeline, and high capital investments required to scale up manufacturing capacity to meet anything resembling the needs in developing countries. So there are lots of risks. Now, you'd think that donors with money could alleviate some of those risks that are faced by developers and by manufacturers. But in fact, in many ways, to date, they have exacerbated those risks. And let me just list a few ways. One is that in terms of the volatility of donor funding, although progress has been made in this area recently, Typically, donor funding for specific countries is very subject to rapid fluctuations depending on whether or not the country is in political favor or the leaders have recently been accused of corrupt practices or other factors. So donor money, much more than tax receipts, is subject to rapid fluctuation. It can't necessarily be counted on, at least in the traditional form in which it's been delivered. So that's one, is budget risks. Second way they contribute to the risky environment is through what might be called policy risks. That decisions can be made, and Carol alluded to one of the most famous ones with respect to the anti-malarials. Decisions at the global level can turn on a dime. When the Global Fund suddenly decided that it was ready because of public pressure to fund, not to fund chloroquine and to fund combination therapy against malaria, nobody else was ready for that change to take place. Not the decision makers and those who are operating the health systems in the recipient countries, not the manufacturers of the products. So the policy decisions that are made are often disconnected from realities and impose risks. Third risk is what might be called a bargaining risk. With relatively few large purchasers of products, the Global Fund, Unitaid that I mentioned before, Gavi, they have the potential to have a lot of influence, monopsony power in the market. Similarly, on the manufacturer side, there are relatively few pharmaceutical companies that are deeply engaged in developing countries. In the vaccine world that I know best, there are maybe only 2 or 3 that have active engagements, and one is quite dominant. So on that side, there's a sort of I won't use the word monopoly, I'll put it in quotes, but there's kind of quasi-monopoly behavior. There are huge regulatory challenges. Each pharmaceutical company needs to have its product registered in now more or less each country. And when you're talking about sub-Saharan Africa with very small countries, microscopic markets, and huge transaction costs in both material and time dimensions to get your product registered, the disincentives for pharmaceutical companies, and therefore through the chain to developers, to engage in that market is really significant. So those are ways in which, to some extent, donors have, either by acting in certain ways or failing to use their money in more appropriate ways, have actually contributed to a risky environment for developers and manufacturers and increased the disincentives to engage, all the while they are pushing money to, or using push money to fund research and development. So I'm telling a little bit of a gloomy story and not giving enough credit to the many advances that have been made, but we're about solving problems, so we have to identify those problems. And I think there are a few solutions that are waiting to be further developed through some policy R&D, and I'll just put those on the table in closing. One is around developing instruments to make long-term commitments to purchase products if and when they are developed, and or if and when they are made, the companies make investments in scaling up manufacture. So binding commitments to buy in the future, something very, very challenging for governments to do, but I think for some products quite essential, so that companies and by extension developers have the incentives to move forward. Much more work needs to be done by donors to strengthen and make more efficient the supply chain, all the way down from the global level to the service delivery point. And we actually recently did a study that looks at the transaction, to some extent, the transaction costs all the way through the supply chain for anti-malarial products, and it's really quite daunting. Better forecasting of demand, so that true business case, a realistic and credible business case can be made. Again, returning to the anti-malarial example, when the decision was made for funders to support the purchase of combination therapy against malaria, they provided to the one firm that had the product, Novartis, they provided an estimate of how many courses of treatment would be purchased. In the end, well, not in the end, but what happened was Novartis scaled up its manufacturing capacity commensurate with that estimate. It turned out that that estimate was off, overestimate by orders of magnitude. And you may have read in the paper about fairly large quantities of anti-malarials by both Novartis and Sanofi being disposed of before they could be used. And then finally, I think the most challenging and undoubtedly for health the most important thing to be working on is to figure out how to link the money that is made available to buy products with efforts to really strengthen systems that can broadly deliver health services. One example is to think about how the money that's available for scale-up of antiretroviral treatment, which really is a lot of money now, can be used to incentivize better prevention efforts. Now, what could that mean? It could mean, for example, that municipalities or districts get access to money or get access to antiretrovirals if they can demonstrate that they're taking particular actions to improve prevention programs. That could operate on the subnational or the national level. I think we have to somehow tie the energy for treatment to the need for prevention. And I think that there are other ways in which the resources for products, which I actually see as expanding, at least over the near term, to be used to strengthen systems, and perhaps in the discussion we can talk about that. So the current question, we've now moved to the third question, which is how to use the money that we have, the new money that we have, in new ways to achieve the greatest health benefits. Thank you very much.
Thank you, Dr. Levine. We'll save our questions for the panel until after all have presented. So now, please, Dr. Alok Bhargava.
Well, this is a sort of an extension of a commentary I published in Food and Nutrition Bulletin 2001. I've adapted it to the role of technology for economic development. It's somewhat more technical than probably some of the sessions, but I'll give you an overview of all the important problems I think that exist in health and development. Now, we know that undernutrition and poor health are intertwined. But fortunately, due to green revolutions and agricultural technology transfers and so on, energy deficiencies are now much less common in developing countries. By contrast, the diet quality is generally poor, and micronutrient and protein deficiencies are widely prevalent. And they have all sorts of consequences, and I'll talk about them briefly as we go along. But one of the things where technology transfers are very important is the area of parasitical infections like hookworm, schistosomiasis, and so on, that exacerbate iron loss and also hinder nutrient absorption. So, for example, there are vaccines being developed against hookworm by Peter Hotez, who would have very much liked to be here, except that he's in Geneva, and it's in trial stages. And of course, I'll talk a little bit about HIV as we go along. So clearly, these technology transfers are very important, but I think it is critical to aim these transfers at specific points in time, because it may be too late or it may be not as effective. Now, first of all, the critical area is, of course, the link between nutrition and productivity. If you're an economist, that's really the bottom line. And we now have quite a few studies showing how well-nourished people have higher productivity levels. Part of the problem, at least in the child labor sort of literature that ILO and other agencies produce, is that they haven't really thought about the link between adult health and children's welfare. And it's rather obvious, and it's even more obvious given the HIV/AIDS epidemic in Africa, where you're finding that it's actually dying parents are being looked after by young children. And in fact, it's hindering not only their emotional development, but also their school participation. I published a paper recently in Psychology, Health and Medicine looking at the school participation and psychological well-being of Ethiopian orphans. And those who have been orphaned by AIDS have lower achievements. Now, obviously, children's intellectual development is critical for future supply of skilled labor. And it is really skilled labor that contributes to economic growth. So I know there's a lot of talk about globalization issues, and if you read newspapers like the Financial Times, you've got all these exponents of free trade, but the fact is that many African countries, the skill levels are low, and they are not going to reap the benefits of globalization, as I argued in another paper, which I can't describe here. Now, as far as the stages in child development are concerned, of course, maternal and child health are very important. We've had very low-cost interventions like iodized salt that has helped reduce neural defects and so on. Of course, iron deficiency anemia is very common, and that is linked with poor diet quality. Now, the fact is that one of the points I emphasized in my earlier article is that demographers haven't quite understood that what are the links between nutritional status of the mother and infant outcomes. So, for example, if a woman is repeatedly pregnant in short time intervals, then that lowers the iron stores. That leads to lower health outcomes for children. In fact, we'll talk about cognitive development in a minute. So birth spacing is really quite critical. And I think here technology can play a very important role, because if you look at a country like Ethiopia, the total fertility rate is around 6.2. But if you look in the Addis Ababa area, it's below replacement level. It's 1.8. And what is the most popular contraceptive used are injectables. And so clearly, contraceptives like IUD and injectables are very popular, except that the healthcare infrastructure in these countries tends to be very poor. And so there are unintended consequences of poor treatment. And I think that's where technology transfer can play a very important role. Now, again, to talk about micronutrient intakes, it's certainly true that physical growth of children is compromised by deficiencies of iron, protein, calcium, and so on. Now, anemia is also very important because it tends to lower cognitive function. And, as I said, skilled labor cannot be produced overnight. It's a very slow and steady process. And, of course, helminth infections also worsen iron status. And, the difficulty is that if you're an economist and you want to do some cost-benefit analysis, it's not that straightforward, because you can remove parasitical infections in the short run very quickly. But if you try to improve diet quality, that requires long-term investments, and, it's not so easy to achieve. So in that sense, I think technology transfer is important, but it has to be viewed in terms of how it is timing or how it is aiming to reduce what type of environmental insults and low diet quality that exists. Now, another important area is lack of sanitation. And sanitation is very expensive for developing countries. In a country where you have a GDP of $120 a year, you're not likely to be able to afford $100 per person on sanitation. So I think that this is an area where, cheaper chemical versions and so on of disposing of fecal matter can be very important. In fact, we saw in Bangladesh, we did a study, and, children's gastrointestinal morbidity was really affected by the water contamination due to lack of sanitation. Now, the other aspect, of course, is child development in school, and many factors are important, like school attendance, mobility, household tasks that the children are doing. And this is becoming very bad in Africa, especially in the wake of the HIV/AIDS epidemic, because children are having to drop out of school and care for their dying parents. Now, school environment, again, is very important, and we know that things like books and teacher qualifications are important. I published a study in Tanzania in American Journal of Human Biology in 2005 showing some of these things. Now, clearly, technology transfers can be important, and, one would like to introduce things like internet and, mobile technology, computers, and so on. But the problem is that the educational interventions in general are very labor intensive. So what one can do, especially in remote area, is to improve teacher quality. And so in that sense, I think that technology transfers are not likely to affect or be beneficial for children in rural areas, but they're more likely to be useful in urban areas. But again, one has to recognize what the strengths and weaknesses of any intervention are. Now, I would just like to mention a few other related issues. One, of course, is of obesity, especially among well-off populations in developing countries. Also, it's not only a U.S. phenomena with 2/3 of the population being overweight, but you've got the educated middle class in developing countries that's suffering from cardiovascular disease and so on due to obesity. But ironically, or rather perversely, actually there's a perverse redistribution of medical resources in favor of technologies that benefit the well-educated and the well-off groups. Now, I made this point in the Lancet in 2001, and it is certainly true that many of these people are very productive, and therefore all these important technologies like bypass surgery, revascularization, all this, they're likely to be useful from an economic growth viewpoint. However, it does induce issues of inequities, especially in access to health. And what is more is that diseases of the poor then are being neglected because, these technologies are fairly lucrative to implement. Now, of course, the AIDS epidemic, I hardly need to tell you, can jeopardize economic development in Africa, especially in countries where now we have these vast problems of orphans of AIDS. And even though antiretroviral treatment is reaching people, and even countries like South Africa are guaranteeing antiretroviral treatment, but it's really very, very small proportion of the people who are receiving it. What is more is that there's emigration of physicians and nurses, and I've just completed a study for the World Bank showing that contrary to what the Physicians for Human Rights argued, that Africa needs greater investments in healthcare infrastructure, which is all very well. The problem is that with increased HIV prevalence, there's actually an increased emigration of physicians. And that arises in part because of the risky work environment, and also because people are worried about their children because they tend to become sexually active at a rather young age. So those who can emigrate tend to leave. So I think this has been documented in a survey in 6 African countries, and it also comes out in some econometric analyses that I've recently done. Now, I think that the critical thing is, from a technological viewpoint, is to find a cure for HIV. And Anthony Fauci had sort of said 10, 15 years ago that we will have a vaccine within 10 or 15 years. But when I saw him last at the AIDS conference in Bangkok, he said there may never be a cure for AIDS. In fact, we don't even know what it'll look like. So I think that's a really critical area where a lot more resources in genetic research and other things need to go. So just to sum up, well, skilled labor is certainly important for economic development. And, many countries have resources, natural resources like in the Middle East, and they've managed to progress. But in many other countries really need to restrict their family size. In fact, this is also true for Africa. And I know it is very politically correct to say that mother-to-infant transmission can be reduced by nevarpine and so on. But the fact is that if these pregnancies are really unintended, then it's not clear to me how the resources should be spent. In fact, we interviewed some women in Tanzania and who were being counseled by medical professionals, and they really wanted to restrict family size. So I think that's a very important thing, especially for educating children and so on. And of course, the interventions or policies depend really on the circumstances of the country themselves, and it's really not possible to devise blanket kind of policies. But I think technology transfer is going to play an important role, and there is a lot of transfer of technology that is going on. The issue really is what is the access, what sort of inequities exist, and how we can make it more effective. So that's all I want to do.
Thank you very much. And our last speaker in the session is Mr. Joe Barnes.
Yeah, I'm being not just less informed, but lazier than the other people on the panel. I'll sit. I come to this from a different perspective. I worked for the U.S. government for many years, and in the third world. And very early on, people were talking about childhood experiences that affect you. Mine was not a childhood, it was an early adult experience, although being a man and not a woman, I remain a child at 50. That always gets a good response from about 50% of the audience. I lived in secession in Sri Lanka and Sudan, 2 countries with very roughly the same per capita GDP at the time, and 2 countries that had civil wars at the time, and yet more striking divergence in public health and indicia of mortality and life expectancy you couldn't find. You actually could find, but they definitely were a study in contrasts. it did teach me the lesson, which is that although there may be a relationship between economic growth, and it's a two-way relationship between economic growth and public health, it's by no means a one-to-one relationship. There are a great many countries around the world that have achieved very respectable, not a great many, but a number of countries that have achieved respectable levels of infant mortality and life expectancy at relatively low levels of per capita GDP. I think Sri Lanka is always cited as one of them. It has a lot of advantages and had a lot of advantages, but it was not and is not a rich country. As I mentioned, the pattern is generally clear. The higher per capita GDP, the better the health results. It's clear also that better health leads to higher economic growth and vice versa. There are elements, and we were speaking about environmentally related illnesses. There is, of course, the extent to which economic growth can lead to illness. It can also just lead to patterns of consumption that lead to illness. We can find that among the Chinese getting rich enough to smoke more and Americans getting fat as pigs. So it's a two-way street on economics. I'm not one to downplay it, but clearly you'd like to look at ways other than just brute increases in per capita GDP to improve health, whether there's technological transfers, financial transfers, introduction of new technologies or methods. I would like to note a couple things, though. I think that Dr. Levine here mentioned one. The thing that's really changed is I was in government, and I was a little bit involved with the preparation of the foreign affairs budget, including the foreign assistance portion of it. There has been a dramatic increase in interest in global health issues, and I agree it started with public advocacy around the AIDS issue. It's a truly dramatic change. It simply didn't loom large. I'm not saying that there weren't interesting and useful and hardworking and committed people involved in it, but it didn't loom large. I think, for USAID as for the major banks at the time, 10, 15, 20 years ago, I think the emphasis was on more general questions of economic growth, and if it was health, once again you mentioned general and not specific. A few facts, I don't know, maybe I thought I was going to be the person with pessimistic things to say. And then I listened to Dr. Levine, and I thought, I don't know. Just a few facts. Remember the United States, we got to a life expectancy of about 65 in 1945 or so. And that I just want to remind you that we're quite capable. I mean, it's objectively possible to achieve relatively good public health with 60-year-old technology. I'm not saying we should. I'm not saying that technology hasn't played a role, but I think it's important to remember, much like an atom bomb, by the way, which is also, although it's frightening to think of, a 60-year-old technology. It didn't require high tech for the United States to achieve a decent level of public health, nor did it take high tech for countries like Sri Lanka and then later China to a large extent to achieve it. This is not to dismiss the important work that people here are wanting to do and are doing in terms of deliveries and vaccines. I think it's something we always need to remember. There have been low-cost remedies in the past. A lot of the stuff is simple. Decent nutrition, drinkable water, immunizations, decent care of pregnant women and young children. I don't know how much of our life expectancy in the United States is due to those 4 items, but I suspect it's a lion's share. And that all the wonderful stuff that occurs over here in the medical center, most of it adds a couple, 3 years to our lives. Once again, I want those couple, 3 years. But I think I think we have to remember these things. There's another thing I'd like to point out, And this is, on the one hand, depressing. On the other hand, I think holds an area for possible progress. Despite the dramatic increase in official U.S. funding for global health, the sums involved are, by U.S. budgetary standards, essentially trivial. As far as I can tell, our total expenditures on global health through the official foreign assistance is about 1% of our defense expenditures. That is, and giving the cost of the war in Iraq maybe roughly $150 billion a year, I'm guessing that our official expenditures on global health are maybe 2 weeks or 3 weeks worth of the war in Iraq. A little factoid I found out: the U.S. defense budget, my friends, is more than the GDPs of all 47 sub-Saharan African countries combined. If it's 1%, if our spending, international spending on health is 1% of defense, it's 0.2% of federal expenditures, and even, what is it? I think actually it was 0.2% of federal expenditures and 0.05% of GDP. That's a rounding error. That's errors in emissions. And that contrasts with the 15% of GDP that we spend on our own health. So on one level, this is a sort of depressing thing to say. On the other, I think it does indicate that there's I realize you're in a sort of a phase right now of where you're trying to figure out what you're going to do with the money you've got, which is increasing. But I think there is room for growth in public support for global health. And I think this can occur despite the long historical resistance of Americans and their representatives to foreign assistance. I think the proof is in the pudding, and I think the dramatic increase in AIDS funding shows that in this area at least, the sort of traditional resistance to foreign assistance in the United States can be overcome. The problem is a very general one in terms of foreign assistance, which is that study after study have indicated that Americans believe that we spend a fortune on foreign assistance. The numbers are just grotesque. But I would say, of all of the sort of claims on foreign assistance, the one that I think probably has the greatest popular appeal is global health. Moving on to another area of negativity. Actually, the last area was not fully negative. My point is this: when you look at improving health in developing countries, I think the first rule should be do no harm. Okay, and I think that when you start to talk about or think about developing and introducing a new technology, you should ask yourself questions. In a world of limited resources, where we don't have infinite resources, will the introduction of new technology displace funding for other more important health measures? Not just among donors, but with the local government in terms of local currency counterpart expenditures. One of the things that can be done to ensure that this question is answered right is to look at the overall health impact and not just the impact on the narrow targeted population. Will the introduction of new technology divert local healthcare workers away from other potentially more important healthcare measures? It's a very important question. Do the new technologies reflect donor desires or recipient needs? Just some discussion here. Then there's a more general and I know very difficult question, which is, will the introduction of new technologies affect wage levels among healthcare workers? Absolute and relative. Will it suck the best trained people, the most committed people, out of other programs into this program of delivery or whatever it is? I'm not saying that the answer in every instance would be yes, but I'm just saying these are questions that should be placed. And the mention of labor markets leads me to to another point on the do no harm front, which is the brain drain question. This is an important question, and it's going to have to be addressed sooner or later, because there is something profoundly silly about spending billions of dollars, even while we're encouraging healthcare workers in the recipient countries to come to the United States. There is something profoundly wrong here. And it's going to be very difficult to deal with, because although there can be some efforts to subsidize salaries in the host country, the way it's stopped, there's two ways to stop it. In the long run, one way to stop it is to increase the number of nurses in the United States getting trained in the United States. This is a huge problem, and doctors as well. The second way is to say they can't come. And this, of course, runs counter to this whole tradition of, movement and education and academia. But I'm afraid that this is one of those issues that's going to have a tough answer, and not an easy one. Now that I see Neil looking at his watch, I'll make one last final plea. I've already talked about looking at any specific introduction of technology or initiative or intervention against a broad picture of the country's health needs. I also urge, if only as a chiding suggestion, if only to raise your awareness, to think about the broader, what I would call, political economic environment in which you'll be working, or your surrogates will be working. If you look at the health problems around the world, there are a lot of health problems, but the focus, as several people mentioned, is on Africa. And the problems in a number of these countries transcend bad health or the AIDS epidemic. A number are failed states or failing states of little legitimacy, poor infrastructure, and often civil unrest. I'm not saying that every medical initiative has to be designed or calculated in respect to this. But I do think that it should be a chiding and sobering reminder of the environment in which many of these individuals and initiatives will have to work. And it may be a good reason to lower expectations up front. Thank you.
5 minutes worth of questions, you think? I mean, all that awaits us is food, but actually the most important thing that awaits us is the posters outside. And so to make sure I don't forget it, grab some food when you go out and start looking at what these wonderful students are doing. I really appreciate it. So let's take some questions, please. Yes, please. Second row, and then I'll come.
Thank you very much. There appears to be something that is conspicuously missing as we go along with the theme. I think good governance has not been addressed in the presentation. We're talking about the failed states. What has failed here is good governance.
Absolutely.
When we're talking about improvements in Sri Lanka and Sudan, the obvious difference is good governance in Sri Lanka, bad governance in Sudan.
Absolutely.
When we're talking about the experience in Zimbabwe, Zimbabwe has the highest contraceptive fertility rate in Africa before the Mugabe problem. I'm sure if you go to Zimbabwe today, it's a disaster. I think we should not shy away from promoting good governance. When you give aid to many of the African countries, and there's no good governance, you are throwing good money into the ocean. And I think global health should actually subsist on a good foundation of good governance. And I think that should be an important thing that many people should promote. International agencies, people who have served in U.S. government should not feel shy to promote good governance in Africa.
Thank you very much.
I'll do real quick. No, I mean, look, there were some different, the results are very different between Sri Lanka and Sudan for a number of reasons, but difference in size, but the truth of the matter is you're right, it's good governance. It was competency questions, competency questions, transparency questions, functioning political system questions. I mean, Sri Lanka, for all its faults, had a democracy for most of them, for all of the time. No, I think the problem, of course, is I know that there are people sitting here saying, "Oh God, the last thing I want to do when I'm trying to introduce a very urgent technology or technique or intervention, the last thing I want to do is get involved with some huge argument about transparency and corruption." I mean, I think that's, anyway, up to you.
Yeah, I mean, I don't have any answers except that I fully agree that over the medium term, strong public health systems, as in sort of any other aspect of development, is built very much on some aspect of what we might call good governance. That tends to be a word that is used to mean a lot of different things to different people. But I guess, you know, the struggle that we're all going to have is if the criteria for where support goes is that the countries need to be well governed, and that is in fact what the Millennium Challenge account, how they allocate their funds, at least nominally. You know, if that's the criteria in the health domain, then we have to tolerate the situation in which people will be more likely to die and not have access to needed technologies because they happen to have been born and live in countries that are ruled by people who have only their own interests at heart. And so, you know, I'm sympathetic to this, but I also think that this is going to create it creates a really tremendous amount of cognitive dissonance. But you get the book.
Yeah, I get the book? Oh, yeah, no, he gets the book. Yes, that's good.
Please, question.
One comment, one question, and that is Dr. Adewale and Rebecca and I are running a project together in Nigeria, and with some ExxonMobil funds, and the ExxonMobil funds have been used exclusively to buy equipment. And he has made each director at each site responsible for trying to match the ExxonMobil funds with local funds. And so this is a guy who has the right attitude. At the same time, I don't think anyone in this room would say that they know Nigeria is well governed. And yet, their current president, in addition to stopping wars in neighboring countries, and beginning to prosecute fraud, also paid off the $3 billion debt and now has $43 billion in the economy. He doesn't like the press. And thus, all we ever get in this country is bad press about Nigeria. A strategically important partner in the oil and energy business, with light sweet crude there being the highest amount in the world, and no one really knowing what's going on. And I would say that there is such inadequacy in the information that comes into this country about all other parts of the world. We hear more about a movie star than we do about an epidemic. It's absolutely pathetic. And we have kids watching Paris Hilton with no values, showing that she has no values, instead of watching something important, instead of learning about one of your careers. Who cares what she does? We've got to get it into the media. We've got to get it into the schools. You've got to get it at multiple levels. It's not going to take hold. People do a lot of unimportant things with their time in this country. It's wasteful.
Anybody disagree?
My question is,
I don't even want to let you know what I watch on TV.
I'm going to hear Sex in the City, I'm sure. But it's okay. It's okay. It's a joke. It's a
I was going to say SpongeBob.
But I think one question is, how do you measure your improvement? So one of the challenges we had going to the WHO was, looking at what population-based registries there were in Nigeria just to measure cancer. There were none that were population-based. So then we've had to spend a good part of Exxon money setting up a population-based registry. How do you know what maternal health is unless you've got somebody counting it? And I think the WHO would admit that for cancer, for maternal health, for infant health, for all the infectious diseases, those are estimates. Medical center-based estimates. Those are not population-based estimates the way we have in our country. So when you talk about planning for resources, et cetera, you are talking about you don't have any data.
Well, that's really not true, because every 5 years, the USAID-sponsored demographic and health surveys collect data depending on the population. So if the population of Nigeria is about 75 million, or
No,
what?
it's 140 million.
It's 140 million. So you would survey something close to 30,000 households every 5 years, and these data are publicly available. So you can actually get not a lot of information on infant mortality, child mortality, fertility rates, and now they're adding the HIV components, especially in countries like India. So it is true, for cancer you may not find ready-made registries. But I think this issue of good governance, I mean, it's too loose, it's too ambiguous as a notion. You cannot compare Sri Lanka with Sudan, because Sri Lanka, the literacy rates are over 97%. I mean, it makes no sense. It's true, Sri Lanka has had lots of problems with its ethnic minorities and so on. So, I mean, I agree that, people like Jeff Sachs are very defensive about this issue of good governance because they don't see it as a problem. I agree it is a serious problem. But I think to make comparisons across countries based on one variable is really very difficult. And as far as health and demographic statistics are concerned, they exist for all sub-Saharan African countries at about 5-yearly intervals. So, it may not have chronic diseases, but I think there is a lot of information there.
Ruth, you have a comment?
Yeah, I have a very niche comment on this, and that is that I think there's an opportunity ahead. That there's a 2010 round of censuses that's being developed now, and it's going to go from 2010 to 2015 probably. And if sufficient resources are put into doing those censuses correctly with the right GIS tags and so forth, that really would provide a tremendously valuable foundation for future sample surveys and so forth. And so it's something that flies way under radar. You don't get advocacy groups going around with little rubber bracelets saying, count people now. But it's hugely important, and academicians have a real role to play in that.
Look, I'm sorry to interrupt this, and I know there are lots more questions, but we're going to start promptly at 1. And so in order to do that and make sure everybody has a chance to look at the posters, I think we need to just thank the panel again and thank you all for coming.